Today, I'm going to talk about a new Endocrine Society clinical practice guideline on the treatment of diabetes in older adults. Now, first I want to say is that this is a very thorough, very complete guideline, although obviously they're always limited by space and time. So even after 2 years, there are a number of questions that remain to be resolved and will happen over time as people get used to this guideline. But what's interesting, and I think very important, is that they walk through various phases. First, they talk about the diagnosis of prediabetes and type 2 diabetes. They then move on to looking at glycemic targets. They discuss a lot about the individualization of care and working with primary care, because primary care providers are going to contribute a lot to the care of these patients. They discuss looking at patients' frailty, their ability to function, their ability to do activities of daily living. And then they go on to discuss the various treatment for diabetes and then guidelines and treatment for both hypertension and lipids. Now, the first part of the guideline, which is in terms of diagnosing prediabetes and diabetes, was to me the most controversial and perhaps the least practical. And what I mean by that is that they suggest that as a second test for diagnosing diabetes or prediabetes, an oral glucose tolerance test is done, and then the 2-hour value from that oral glucose tolerance test is used to diagnose prediabetes or diabetes. Now, I am, as probably most of you, most used to using a fasting glucose level or a hemoglobin A1C for diagnosing diabetes or prediabetes, but they made a very cohesive argument about how an A1C sort of falls away in terms of being useful as a population ages, particularly in individuals greater than 75 years of age, those with chronic renal disease, and those with various states of anemia. So the reason they basically suggest that 2-hour value is because they feel in the older population that will be the most accurate way to diagnose diabetes and prediabetes. From my perspective, I will still look at both the fasting glucose value to see if that's elevated and or a hemoglobin A1C, but then obviously do a confirmatory test. And say, for instance, if a fasting glucose was 115 and you wish to do another confirmatory test, that could be, according to the guidelines and is suggested, a 2-hour glucose tolerance test. But practically speaking, I'd probably still do an A1C, both because that would be involved in guiding my treatment, as well as then help me diagnosing the patient, because if the hemoglobin A1C was elevated, it's likely to be indicative of the patient having diabetes. But again, they really clarify that if you want the most accurate way to diagnose prediabetes and diabetes in this population, that you need to consider doing the 2-hour glucose tolerance test. They then go on to look at targets, and it's interesting because this is the first time I've really seen a lower target given. So instead of saying the A1C should be less than 7, less than 8, less than 8.5, they basically look at patients to see whether they're on a drug that can cause hypoglycemia or not. And if a patient's on a drug that can cause hypoglycemia, such as insulin or a sulfonylurea agent, they have a lower part to that range. So they don't want patients below a level in order to avoid hypoglycemia. So one part of their table for targets basically looks at whether you're on drugs that cause hypoglycemia or not, with a different range for those who are on agents that can cause hypoglycemia. And then they divide patients into sort of 3 functional categories. And it's not actually based on an absolute age, but really in terms of how well the patient can achieve those targets, whether a patient has comorbidities, whether they have elements of dementia, and whether they're really able to take care of themselves and do the diabetes self-care tasks. So I think they did a really excellent job at making a framework for defining targets for patients as we proceed forward in treatment. Then with regards to treatment, they have nice tables where they list the pros and cons of various treatments, and they stress the importance of limiting hypoglycemia and, if at all possible, avoiding agents that can cause hypoglycemia. throughout this, they discuss working with the primary care team, working with the patient in terms of the patient's preferences and tolerances, and really moving forward in a way that involves a group, a team. And I think in particular, an important part of the team is a registered dietitian, someone who can work with patients as they age to help them eat in a healthy way. There's a lot of discussion about the sarcopenia that can happen. What happens is patients lose their appetite, eat less, start to weigh less. A lot of that is important as patients age. We need to keep them healthy. We need to have them eat enough protein and really have a diet that keeps them going, keeps them strong, but also is as consistent as possible, again, particularly if they're on drugs that can cause hypoglycemia. Then after discussing management of glycemia, they look at the management of both lipids and hypertension. The lipid targets are somewhat complicated just because there isn't a lot of data in an older age group, but they stick fairly closely to the standard targets, looking at risk, looking at an LDL of less than 100 or less than 70 in those higher risk patients. And they're fairly standard lipid lowering guidelines. Again, they discuss individualizing treatment and looking at what a patient really might benefit from. As people get older, polypharmacy becomes quite an issue. And so we need to make judicious choices along with our patients about treatment. And finally, when they look at the management of hypertension, they discuss a target of less than 140/90 for most patients. But then in patients where they have other conditions such as chronic kidney disease, where you need a lower blood pressure, they discuss a target of less than 130/80. They do talk about concerns about orthostatic hypotension and autonomic neuropathy in people with very long-standing diabetes, and advise considering this as targets are titrated and reached in individual patients. So I think these guidelines are very expansive, they're very useful, they're very well evidence-based. The one thing they don't talk about but mention is specifically how to de-escalate therapy, because I think it's important to stop medications as indicated to help patients stay healthy and maintain use of medications that are effective. But overall, I think it's a great guideline, and I encourage you to read it. Thank you.